everyone. My name is Claire Pomeroy. I am GYN Marketing Manager for Intuitive Surgical. Intuitive Surgical has teamed up with Hysterectomy, Pass the Pearls, and the Hysterectomy Association UK to bring to you this Hysterectomy Awareness Month activity. In a recent survey that Hysterectomy did, 44% of women were unable to answer the question, what is a hysterectomy? And yet, 1 in 3 women by the age of 60 will have a hysterectomy. And it is the second most common surgery for women, only second to C-section. So this May is the first Hysterectomy Awareness Month. Again, it is brought to you, spearheaded by Hyster Sisters, partnering up with Pass the Pearls and Hysterectomy Association. The month aims to raise the dialogue, educating all women about GYN symptoms and diagnosis that may lead to hysterectomy. And really, we want to educate women for better GYN outcomes. We are going to have a live Twitter chat and e-chat, both on Twitter, Facebook, and will be posted on the Hyster Sisters website, on symptoms that you should never ignore. Topics we will cover today include pelvic pain, bleeding, fibroids, endometriosis, and GYN cancer. So with that, I'd like to introduce to you our surgeon expert, Dr. Arnold Vincula. Dr. Vincula is the current AAGL president. He did his training at Temple University School of Medicine, his residency at UNC Chapel Hill, and then his fellowship in minimally invasive GYN surgery at Chapel Hill as well.
It's always nice to see, we come to ACOG every year to learn about the latest advancements in women's healthcare. And it's nice to be able to look at Hysterectomy Awareness Month happening at the same time that ACOG is occurring, to be able to partner with patient advocacy groups like Hyster Sisters, which a lot of us as clinicians use as a resource for our patients when they seek further information about procedures that they're going to have, particularly hysterectomy, and then also, of course, being able to partner with various device companies, and in this case, it's with Intuitive Surgical, who provides us with products that we use when we take care of our patients. So it's nice to be able to answer questions from patients live, coming through the website, to be able to educate them with regards to any questions that they may have about their health care, as well as anything related to hysterectomy. So if we can go ahead and get started, Claire, do you have any questions that are coming in from the feed?
Definitely. So if you want to follow this live on Twitter, it will be with the handle @hysterectomy411. You can also send us questions with the hashtag HysterectomySmart or hysterectomy awareness. So we'll get started with the first question. This came in online in this past week. We've been told that pain during menstruation is normal. What are the signals that pain is not normal?
That's a great question. It's a question we often get from patients about their pain during their menstruation. There are really two sort of buckets. There are those patients who actually do have what would be typical menstrual cramps that occur with their cycles. We call that primary dysmenorrhea. It's usually not associated with any type of pathology, and it's often able to be managed with birth control pills and with anti-inflammatory drugs. Things like Motrin or Anaprox, non-steroidal anti-inflammatory drugs. But one of the things that we're always concerned about when women complaining about pain with menstruation is, could there be some other underlying pathology? Could it be related to what we call secondary dysmenorrhea? And that can often be attributed to things like fibroids or adenomyosis, endometriosis. So when we hear that patients have this and it's progressively worsening over time, so one of the hallmarks is progressively worsening menstrual pain as they get older, becomes refractory to birth control pills or non-steroidal anti-inflammatory drugs, then that's the time when you should, as a patient, seek a consultation with your clinician, with your OB/GYN provider, to find out more and to get evaluated. Sometimes it's just a simple exam, other times it requires an ultrasound or some further workup to figure out why you're having that pain with your menstrual cycle.
Very good, thank you. So this is from a 55-year-old woman who's overall not feeling well, feels bloated. Chronic constipation. Is this something she should discuss with her family doctor, or could this be GYN related? She is menopausal.
That's a great question to ask. There's actually a lot of components to this. First of all, I think it's always important, if you have symptoms, being able to reach out to somebody, whether it's your primary care doctor, your family medicine doctor, your internist, or your gynecologist. I mean, that's important. In a situation like this, that primary diagnosis of chronic constipation could go to any one of those. Even a physician extender, like a nurse practitioner, would be a good first line to be able to see somebody about that symptom. When we hear about those things in an older postmenopausal patient, we always worry about the possibility, could that be related to something pathologic, things like ovarian malignancy, could it be something related to the bowel itself? So at the end of the day, it's an important complaint that could have multiple causes, multiple etiologies. And so clearly it's something a patient should seek some consultation for, and then allow a workup to be done, often an exam as well as some imaging will most likely be done. And certainly chronic constipation, again, could be something as benign as just change in your diet or irritable bowel syndrome, but it can also point to some other more worrisome things.
Very good. So we do have one directly from Twitter that just came in. The question is, has anyone experienced ovarian remnant syndrome? And if so, how is it treated?
That's another good question. Ovarian remnant syndrome, just to define it for the audience who is listening or following this on Twitter, is a condition where the patient should have technically had their ovaries removed. But unfortunately, there's a portion of it that's been left behind and can be a potential cause for pain. So there are a lot of ways that can be treated. But first of all, you have to confirm the diagnosis. And so there are different ways to provocatively do that through laboratory testing as well as imaging. But once you feel confident that the patient likely has a remnant left behind, then some of the ways to treat it are what we call hormonal suppression, where you try to suppress the ovarian function that's still residual in the remaining ovary, or that piece of the ovary. If that doesn't work, then one of the more extreme things that we often do to patients to help cure them of that problem is to surgically remove them. And it really requires seeing a specialist who understands how to treat that surgically. That needs to be done. It's definitely something that requires a comprehensive evaluation to take care of.
The next question came in from a 28-year-old who's bleeding about 10 days per month with 4 heavy days per cycle. On those days, she has to stick close to the house because she bleeds through the pads of tampons. Is this something she should talk to her doctor about, or is it normal and nothing to worry about?
Yeah, well, certainly anytime anybody's having that long of a menstrual cycle, bleeding that heavy that it really impacts their quality of life to the point that they can't even leave the house, that certainly requires a evaluation by their primary care physician or by their gynecologist. And certainly, again, there are a lot of reasons why a 28-year-old woman can have that kind of heavy bleeding. Often it's maybe just hormonal irregularities in terms of how they cycle. They could have menstrual dysfunction from that perspective, but they can also have things like fibroids and endometriosis polyps, a variety of conditions that could definitely lead to heavier menstrual cycles. And again, things like fibroids being one of the more common things that we see in young women. So certainly that is something that she should go talk to her doctor about. You also want to make sure that you're not anemic. That's another thing that can happen from excessive bleeding like that.
This one is from a 45-year-old woman who's been diagnosed with fibroids. There's some discomfort, but nothing severe. How does she know the best course of treatment?
That's a good question. Not everybody with the finding of a fibroid needs to have that treated. So, it's good to, first of all, be evaluated by your physician, make sure that there are no other underlying conditions that need to be addressed. But, we see many women in our offices who may have a single fibroid or several that are overall asymptomatic, not causing any problems. And if their menstrual cycles are relatively normal, they can certainly be followed, particularly somebody who is somewhat close to the perimenopause. You can certainly continue to follow that, and over time it may, even with menopause, shrink slightly. But certainly, as long as she's not really having any symptoms, there's no compelling reason to have to do anything interventional once the workup's been appropriately conducted.
So here's another one. She's a 38-year-old woman who has been diagnosed with many fibroids. She has not been able to get pregnant. Is there fertility-sparing surgery that might give her hope of carrying a child?
Absolutely. First of all, infertility is multifactorial, so you have to go through a good workup to figure out what is the main cause of that infertility. Fibroids have certainly been implicated, and a lot of it depends on the size and location. If it truly is a fibroid, then there are options for patients, including hysteroscopic as well as laparoscopic approaches. Certainly one of the laparoscopic approaches could either be by conventional laparoscopy or what we call robot-assisted laparoscopic myomectomy. So there's definitely hope for this patient. She just needs to make sure she gets the adequate workup and sees the appropriate surgeon who knows how to do the fertility-sparing surgery.
So we have posted here, as well as we'll be posting on the at Hysterectomy 411 Twitter handle, a couple of pieces of information about fibroids, both symptoms that you may be experiencing, as well as different treatment options. Do you want to run through some of these here?
Well, certainly a lot of them are the things that we talked about fibroids. Obviously, bleeding is one of the big symptoms that patients will see. They can have discomfort, urinary frequencies, definitely one of the things that our complaints patients often come to the office with, is the pressure on the bladder. And again, a lot of the treatments are doing things as simple as observation or expectant management, all the way through medical therapies, some of the non-invasive treatments like uterine artery embolization, all the way to surgery. So again, patients have a lot of options. They need to be able to undergo the appropriate workup and see the appropriate physician who can provide them with what their different options are and hopefully execute the appropriate one for that given patient.
So there was a question from the audience. Is LAP the only way endometriosis can be diagnosed? The patient had a LAP at age 18 and they found no endometriosis, but she has ongoing unexplained pelvic pain. She's now 23. What should she do?
That's a tricky question. Obviously, we can make the diagnosis of endometriosis one of two ways. We can certainly do that presumptively, just by clinical symptoms, but that isn't always the guarantee that that's the right diagnosis being made. So when we're not 100% sure and we really want to confirm it, then we're going to move towards doing a diagnostic laparoscopy. In a diagnostic laparoscopy, that has a lot of caveats because it requires that the surgeon doing it understand that endometriosis can look very different in different patients and can take on different appearances. So, she may have had it at age 18, she may not have. It's always good to see if there's any evidence for a confirmatory biopsy report. And even if it's not seen at age 18, it doesn't mean that by age 23 she couldn't have evolved and developed it to the point that now there's something visible that can be seen. So, again, my advice for patients like this are to seek the appropriate evaluation by somebody who is well versed in treating endometriosis. And at that time, decisions can be made whether it can be provocatively diagnosed and treated medically or whether that person needs to have a repeat laparoscopy to really further evaluate what's going on.
So just as we did about fibroids, we have some more information for the audience about endometriosis, both the symptoms and some of the treatments. Do you want to run through them?
Sure. Again, classic hallmarks are progressively worsening menstrual pain, infertility, pain with intercourse. Those are some of the hallmarks that when we start to hear about those from our patients, we think endometriosis, and we either can try to treat it presumptively with simple conservative medical therapies, or if we're really concerned something's going on, or if we detect something on clinical examination, radiologic imaging, then we can move immediately to surgical evaluation and treatment. So again, there's a lot of available options for patients, and again, the important thing for the people logging into Hysterectomy or to any of the patient advocacy portals for finding more about hysterectomy is that they need to ask lots of questions and know that there are lots of options available and seek those out from their provider.
So, 45-year-old woman has inconsistent menstrual cycles, some heavy, some light. She has some breakthrough bleeding. Her doctor tells her she's just getting pre or perimenopausal. However, she has no other symptoms of menopause. Past are normal. Should she insist on more testing?
So again, these are great clinical scenarios because they're the types of things that we see in the office quite regularly as GYN physicians. But when we see patients who are in their late 40s, perimenopausal, with bleeding irregularity, we always have to think in the back of our mind, could this be also related to some underlying pathology? Could it be hyperplasia? Could it be early endometrial cancer? So often I do recommend that patients come in and be seen. I don't just assume that this is a simple transitioning period into menopause. We always want to make sure that we're not missing something that can be readily diagnosed with things like a simple ultrasound, simple endometrial biopsy done in the office to make sure that this patient is going to do fine. And often it may not need any treatment whatsoever, or other times it may require simple interventions like hormonal therapies or even simple non-invasive surgical treatments.
But I think an important part here for women to be their own advocates. You know, if a woman's doctor she's not comfortable with the workup that she's getting, you can go out and get another opinion from somebody who may be willing to do more testing. You're not cheating on your doctor if you do this. It's absolutely okay. So you need to be in hands that you're comfortable with. A post-menopausal 60-year-old woman is bleeding, not just spotting, but bleeding for weeks at a time. It really isn't stopping like a regular menstrual cycle. What do you recommend to this patient?
Postmenopausal bleeding is always one of those important symptoms that raise red flags for us when we see patients in the office. And automatically, a patient coming in with postmenopausal bleeding is going to warrant a thorough evaluation. And one of the key things that we're going to do is what we call an endometrial sampling. Most of the time, we can do that in the office. We can't do that in the office. We do that in the operating room as what we call a D&C. Sometimes it's tied together with a diagnostic hysteroscopy so that we can understand why in the postmenopause she's bleeding. Again, most of the time these are going to be benign reasons like endometrial polyps, but occasionally this can be due to things like hyperplasia that are sometimes even then lead to endometrial cancer. So clearly, a patient with this condition should definitely seek consultation with their primary care provider or their GYN provider to get this worked up pretty quickly.
So on the topic of GYN cancers, Dr. Gynecology just mentioned one of those things you should be very aware of is postmenopausal bleeding. Here's some other symptoms and treatments for GYN cancer.
Yeah, absolutely. I mean, the bottom line is patients, when they have symptoms similar to this, shouldn't just chalk that up to necessarily benign conditions. It should definitely seek evaluation. Again, the treatments are going to really be based on what the diagnosis is. It's very hard to say right now what is this patient going to exactly need. But based on the workup, there are a variety of treatments that are available for patients if they are diagnosed. But again, what's really interesting is a lot of times we have this high on our differential, and although it's listed there, by the time we complete the workup, things are typically benign at the end of the day. So I think that's very reassuring for most of these complaints.
Patients are seeing a lot of articles about morcellation in the news, but they're not quite sure what it is. Can you explain to the audience what morcellation is, as well as how it may change the way their surgery is done?
Yeah, so to all the women tuning into this broadcast, in terms of morcellation, first of all, I think what's important is to define it. The problem is that word has been, just in general, given a negative connotation. All the word morcellation means is to cut tissue. And it's something that surgeons across every specialty do every day in operating rooms around the world. The controversies really lie behind the use of a device that's a power tool to mechanically cut it. And so there's been a lot of concern over the use of that product, and there's been FDA warnings about it. And to be honest with you, most hospitals around the country have either eliminated or minimized the scope of use of that product. So when you hear doctors talk about morcellation, it doesn't necessarily mean they're using a power tool to do that. There are a lot of ways that we as minimally invasive surgeons, including myself, extract tissue that we treat or take out minimally invasively. We do that in what we call contained systems with different types of methods that don't rely on a power tool. So I think the important take-home point for patients who are listening and tuning into this is that you can actually still have a minimally invasive surgery by a variety of routes, have tissue safely removed, and it doesn't mean that you're now destined to only have a basic open surgery. I think that's the key thing about morcellation. So unfortunately, there's too many misconceptions being propagated in the media that have confused a lot of patients. But again, it's important to ask your doctor how they're going to do your surgery and what kind of approach they're going to take to get whatever tissue they're removing out.
We've been hearing a lot in the last few years about mutated genes. What does this mean, and how does it affect the patient directly?
Well, this is a difficult question to answer because it's a big topic. And when we talk about mutated genes, we often think about things like BRCA carriers, BRCA1, BRCA2, things that have been studied extensively that when patients possess those mutations, place them at a higher risk for developing things like breast and ovarian cancer. So, if there are family histories of certain types of malignancies within a family tree, if there are concerns that a patient has over having experience of malignancy themselves, they should certainly seek consultation with the appropriate individual. A lot of times genetic counselors are brought into play to talk to patients about what these mutations mean genetically, and what it also not necessarily just means for the patient, but also for any offspring, particularly daughters. Other implications for that.
If we have a family history of breast, ovarian, or uterine cancer, it's important to be tested. What if our test results are positive? What if our test results are negative? And how does the patient decide how to proceed?
When you look at family histories, and if it's pretty extensive, it definitely should get tested. Because again, the implications are significant. If the individual tests negative for these findings, it doesn't necessarily mean that you're not at risk for getting cancer. Clearly, anybody with a family history is always going to be at a slightly higher risk than the general population who doesn't have a family history. So, when it comes to getting tested, it requires making sure that you're getting the right counseling from your gynecologist. It includes bringing in genetic counselors so that you understand what the meaning is of the genetic results. And so there are a lot of implications. So negative result doesn't necessarily mean you're out of the woods yet. Because again, it puts you in a slightly different category than a person who's never had anybody in their family with any type of cancer.
And we have one final question from the audience.
Sure.
So this is for women who are in their late 40s or 50s. They are still having their period. They're just kind of getting sick of it. How do you tell those patients?
Again, it all depends on what's been tried before. So as long as they've had an adequate trial of various therapeutic options, whether it be hormonal therapies, sometimes you can do things like a Mirena infusion device, you can use endometrial ablation. If a patient's gotten to the point where they've exhausted all other options and they really are significantly symptomatic and it's impacted their quality of life significantly, then for patients it is perfectly reasonable to consider options as to the end in terms of hysterectomy. So again, it's the whole range from the suspected management all the way to hysterectomy, and for many women, hysterectomy is absolutely the perfect treatment option for them. There are wide varieties to do that. Women who have hysterectomies done vaginally, through conventional laparoscopic or robot-assisted means, as well as some cases require a traditional open surgery. So definitely, that's one of the options that is definitely worth entertaining once the adequate workup has been done and they've had an adequate trial of conservative medical or surgical therapies.
Well, I want to thank you, Dr. Vincula, for engaging this conversation around Hysterectomy Awareness Month. Again, you can follow the cause at Hysterectomy 411 or visit www.hysterectomy.org.
Yes, and again, to the patients who are tuning in, definitely, there's nothing wrong with seeking a second opinion and learning more about their condition and whatever treatment options that have been given to you. I mean, that to me is one of the most important things, and I personally encourage my patients to do the same thing. So, again, thanks to those who tuned in, and thanks to Intuitive Surgical and to Mr. Sisters for, putting the focus on the patient, who is ultimately the main individual that we all want to elevate the care of and be